afternoon, colleagues. Thank you for staying in the afternoon of the last session, but I do understand why, because it's such a incredible group of speakers. And I also want to thank the great team from the Versa group, Rob, who's I think Jessica's father, and Salah, McKenna. We want to thank her as well. So we also need to thank James, the audiovisual squad, for having a flawless performance. So perhaps we could say hello to James. My topic today is, can osseodensification improve the outcome for all on 4 case types? Yes. Good afternoon. Thank you for your attention. Oh, you want more? Okay. We're in Orlando, Disneyland. Trust the guys with the gray hair or no hair. This is, I think, how much height we can grow in the sinus if we follow the various protocols. Last night, we're hanging around. This is why I love coming to these kinds of meetings. We have friends from schooling, friends from colleagues in our neighborhoods, friends from other countries. After this little picture, we all went out on the patio with Sam, the Russian guy, and it was like, we have to prepare for our lectures. He wouldn't let us go. Only 20 ounces. Only 20 ounces. How many did we have? 6 or 7 20 ounces. This guy, we actually don't even know who he is, but I did see him. He's in the back. I did see him later today. We invited the ladies, but he showed up. We have handsome guys, young guys. I don't understand what's going on over here. I gave Maurice like the guy thing, and Ziv, I don't know what's going on there, but it's nice. So, my presentation is about all on 4 cases, which is a particular concept. It's not the only thing that I do. It's not the only thing that everybody in the room should do, but it follows a lot of things that we learned over time. Now, when you get to be my age or Picos' age, we're like father time. I mean, we've like discarded things that we, did years and years ago. But all of these concepts come into the treatment planning and the delivery of the all-on-4 case type. Standard and various prosthetic materials, and I write on the bottom, and soon, osseodensification, because we can, in my opinion, optimize the site and therefore optimize the outcome. So, typical things that we know about in our case planning. Just a trip down my own personal memory lane, I used to teach Nobel Guide. I don't know if anybody has ever taken those courses. You could raise your hand. I might ask a couple of questions. So Marnie has 3 people. When we used to teach those courses more than 10 years ago, the first 40 minutes of the course was on teaching the doctors to use a mouse. Now, I used to teach it with a guy in New York. He would be in the front of the room, and I would say, Jeff, would you do this and do that? And I would stand in the back of the room, because this way I would be able to see the computers, and I made sure that everybody stayed with us. It was like a Marine training. We left nobody behind. So it was actually a pretty good course. Do any of you remember that Mac computer mice were reverse buttons than the PC mice at that time? Now I believe it's like interchangeable with the Mac, but the PCs have always been the same. Now why do I tell you that? Because half the room are young, enthusiastic people who have no idea what I'm even talking about, and then the old guys, they know exactly what I'm talking about. But I'm just telling you, it's an issue. This is a case that we did with what was called teeth in an hour. It indeed took less than 1 hour to do the implant placement with a fully guided Nobel Guide template, and the prosthesis went in the same day as a final prosthesis. You see clearly an implant is missing here. At about 3 to 5 years, I don't really remember, that patient lost that implant. Now, I have a whole nother lecture that's called the good, the bad, and the ugly. So that case I would put into what's called bad. It's not like a great outcome, but it's not ugly because she's still been wearing this for some time. The lower arch was done with a different protocol, not fully guided. As you go over to this case type, These are nice case types. We could place the implants in. You could use different diameters, different lengths. You want to get them lined up like Buckingham Palace. However, if you add up the price for these cases, they're way expensive, except for Isaac, who has a very, very high-end population. But these are, what's in South Africa? You guys like dealing with wealthy people? These kind of cases can cost a lot of money, so we can't treat everybody with these kind of protocols. Hello, trying to move. Okay, there we go. This is my very first Nobel Biocare, Nobel Pharma, Bradmark style case in 1988. The guy came in about a year ago. Oh, Jack, you got to help me. It's rubbing my tongue. I go, what's rubbing your tongue? So the screw axis hole opened up. But that was the high water kind of design that we used to use in those days. So for that many years, almost 30 years, he had a nice prosthesis on implants. And you can see there's typical prosthetic wear, but that's what happened. My own personal experience, I also have been a friend, associate, traveler around the world with Carl Misch, and a student of Carl's ideas. And in the 1990s, it was the biomechanical concepts that I really enjoyed of Carl, and we tended to over-engineer our case types. So that's something that we used to do. Now, consider the price tag on some of these things. Now, this is a grouping of cases done by some other colleagues, not me. Agliardi and Malo, I forgot whose case this is. If you recognize it, it's one of your friends. I apologize to that person. But these are up here to show you that there's been a global evolution to the all-on implant or all-on-4 case type. And all of these were from European colleagues. And what's interesting about this case modality, it's a graftless and more affordable type of a protocol that's been designed to help and treat more patients. That was the whole rationale behind it. Every case that we do is not like this, but it's a good thing for patients that have modest money. I give credit to Professor Bradmark, who I was inspired to do this upper case on this lady about, I don't know, 25 or 26 years ago. Typical Bradmark protocol. We had nice, good implants, and she had an intact dentition. Then about 6 or so years ago, the lower teeth failed. We converted her to an all-on-4 case, delivering a prosthesis the next day. She couldn't believe it. She was like crying. She said, wow, because our experience on the top took a year and a half. Teeth out, denture in. 6 months later, implants in. 3 months later, 3 of the implants came out. 2 months healing, 2 more implants in, dentures relining, so on and so forth. That's what we used to have to deal with. Anyway, this is what I'm thinking about now. She was thrilled, and it was like $20,000 less than it was 25 years earlier. So I give these two colleagues credit. What took place during these time periods? Surface enhancement. We had some beautiful lectures earlier by Coelho, Treasy, Meyer. These colleagues were teaching us how osseodensification is histologically sound and how the implant surface makes a difference to the native bone. But the implant companies have improved the surfaces. Or did they? Or do we still need to know? Or will we find out down the road? So it's all of the above. But I've always followed the various surfaces, and I like what I'm seeing. Some of the companies have calcium impregnated. Some of them have fluoride ion materials. So there's a lot of nice improvements when you've been in the field as long as I have. This article was one that blew me away years ago. I used to be an editor of this journal called PPA&D. It doesn't exist anymore, otherwise I'd probably still be an editor. But anyway, PPA&D was a very cool, well-graphic, beautiful photographic article. So I got this article in 1997 because I'm one of the editors. So I got to read it first, and I said, this article is so cool. Every day that I'm doing implant placements, something about this article comes into my mind. It deals with implants to implants, implants to teeth, implants to extraction sockets, implant to healed sites. It talks about the height of bone. And we see tremendous advantages that we at this conference. The partial extraction concepts, the socket shielding. You saw a lot of young colleagues. Let me give a shout out to Jorge. Where are you? Okay, it's hip, 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 Jorge. Hip, hip, Jorge. So these guys are doing like amazing stuff. So I'm still like excited to like be here, try this stuff out. We saw periodontal ligament get a new name. Do you know how like amazing that is? I came from the University of Pennsylvania and Boston University where they invented periodontal ligament. And you just changed the name. It was fabulous. I loved it. Anyway, this article was cool. Maurice, you still here? Oh, cool. There's your article. Very nice. All right. Now, did anybody see this chart in this meeting yet? No, but you saw 9 versions of it. It's the same chart, but in a different version. What's important to me? The amount of time an implant is at risk and the amount of risk there is on that particular implant. So we want to make this little red zone as small and short as possible. Does osseodensification help? I think we've seen some, he's nodding, yes, good man. He gets his credits. You've been paying attention. I think osseodensification is definitely doing several things. It's shortening the amount of time that implants are at risk, and it's improving the density and the outcomes. So I think it's a very interesting concept to consider. Ostel. Did anybody at this meeting hear of the word Ostel at this meeting yet? Yes. Okay, here's a question now. How many of you have an Ostel unit? Approximately a third, maybe, at most a quarter. How many of you are going to get an Ostel unit? The other quarter. So half of you still don't even care about it. We the presenters, we love it because it gives us a objective measurement of what's going on. Sometimes some of my teammates, they go, oh, the implant is solid. Yep. Oh, the other one, it's soft. So we have now something that it doesn't just feel good, it's actually a numerical number that's teaching us that it is good. Now, I'm quite frankly blown away by my young colleagues with their Ostel ISQ readings. I see Isaac pulling in like 80s and Jorge in high 70s and middle 80s. I get lower numbers, but they're still good. My threshold is medium stability. If I get a 65 on a grouping of implants, that is telling me that if I mechanically lock those together, I can go forward and do an immediate load case. Because the implants support the prosthesis, and the prosthesis is a cross-arch biomechanical advantage to help stabilize the implant. It's much like broken leg, that when you're walking with a crutch, it does give some stimulation to the situation. So I think cross-arch is critical. So obviously the cases that I'm showing will be cross-arch. So for me, if it's a 65, I'm ready to go. Honestly, I have not gotten an osseodensification reading lower than 60. They're mostly 65 or above. So I don't see that anymore. Non-osseodensification cases, I have seen it lower. This is a medical CT scan. I took it, I don't know, 12 or 15 years ago at a patient hospital, went over there. And remember the little stories we used to hear? Patients had density 1 bone in the symphysis and density 2 in the premolar region and 4 in the maxilla and 5 further back. Well, let's take a look. Here's a patient I sent out because I was doing bilateral posterior mandible. I think right here is probably a density 2. Here, I think it's a density 1. Here, I think it's like a density 4. Here, it's a density 3. Here, it's a density 5. So I'm not so sure that that concept that it's, regions of the mouth is where the density is particularly exact. So I'm saying to you here that the density can be varied. Now, you saw Ziv's cases. He has cases with 0 density. He doesn't even have any bone and he's working on them. Now, I also like art and things of art almost as much as I like implants. Now, do any of you know this particular piece of work? Madonna and Child. Yell out if you know it. Okay, I'm glad a few of you do, because sometimes I'm with illiterate people and they don't even know what I'm talking about. Michelangelo, took him 3 years. It's like an old Branimar case. Took him 3 years to complete the case. Now, this is in Bruges. That's in Belgium, at a cathedral. It was the first piece of artwork that Michelangelo sold to wealthy people out of Italy. Then, in World War II, this was one of the sculptures that was stolen by the Germans, and it was found in a salt mine in Austria, buried deep into the mines with blown up entry. So people discovered it, had to dig it out, and it was returned to Bruges. However, I didn't see it in Bruges. I saw it in Florence, Italy. It was on a display at the same museum that had the David. Now, a little known fact, when I was younger and thinner, I used to be the model of the David. Anyway, that's where it was, at that museum. And I looked at it, and here was the display. You had the statue here, and then they had pictures of what it looked like all around the sculpture. And I said, wow, it's like a three-dimensional piece of information. Now we, in our clinical practices, are looking at three-dimensional information. So I was like totally blown away and excited by this particular display, and I took a picture of it, and I'm sharing it with you. Now, if you don't know where you are, you may develop what's called air integration. Air integration are implants that are partially supported by air and partially supported by other tissues. Gans and I presented that in 2008. Gans invented it in 2007 in Tanzania. I go to the dental school. Dr. Krauser can come to the clinic, but I usually teach lectures, not clinic. So I go down and see what's going on. This patient was in the study at the dental school. What tissue graft should we do? Picos, what should I do? I go, are you kidding me? To fix this? Forget about that. I mean, that's like a little labially placed. Or there's some recession. Did they do planning? No. Did they do osseodensification? No. Did they prepare the tissue, the bone, anything? No. So the problem is, it's in a study where the prosthesis is successful, so it's called a successful case for the particular data. So be careful when you read studies on things. Anyway, my suggestion was to take it apart, build it back up, and take care of it that way. Now, this is a case loaned to me by Park. He is a fantastic clinician, highly trained. He was a student of Thomas Hahn at UCLA. He practices in Korea. We should all be as fortunate as him. He has like 5 clinics that are huge. They were like ultra modern and amazing. So he let me borrow this case. Nothing against his work yet, but I call this case Chewbacca. Do we all know who Chewbacca is? Who knows who Chewbacca is? Howie, you have a Chewbacca where you are? Maurice, you got the kids. Okay. Who is Chewbacca and how does it relate to us? Chewbacca is this patient who comes in after 2.5 years with these things and goes, Did you ever have a patient like that? Chewbacca. So why do we have, you know it in Spain? You want me to give it to you in Spanish? Oh, yeah. But anyway, it's... We could talk all day about that picture. There's so many reasons. The design, the top, the connection, the prosthesis, the connection, soft tissue, hard tissue. Every single thing I put on the first list was a problem there. But what do you do in a case like this? Patient comes in, paid, at least at Picos' office, $175,000. What are you going to do? There's enough money to do it again. But anyway, Chewbacca. Prayer, that's what we do. It's one of the best peri-implantitis treatments. Is Dan Cullum still here? Cullum. You here? Remember, I think you taught me that. Didn't you teach a case and showed a bad outcome and said the only thing to do is prayer? Well, I'm giving you credit because you inspired me to pray. So this happens to be a tapestry at the Sistine Chapel. A little known fact, but true. In the old country, my family in the late 1800s were coppersmiths. We were hired by the Vatican to do some work on the, what's it called, the cupola of the Sistine Chapel, which is copper, a long time ago. What happened to the family, I have no idea, but now I'm doing dentistry. Anyway, this is a tapestry at the Sistine Chapel. I pray in churches The Temple Mount in Israel, it has a mosque and a synagogue. The great Cathedral of Cairo, I mean not cathedral, Mosque of Cairo. The great synagogue in Rome. If I pass a religious place, I step in just for a couple of good words. Now, doing all on four. Have you ever heard the thing all on four, none on three? Unfortunately, my good buddy Carl was the one that used to tease me about that, and others. But it's not true, and it is true, it may be true, and not necessarily true. Carl's mentor, Ken Judy, did this case in 1994, all on three. I've been maintaining that patient since 1996 or 7. Nothing happened to the patient in the implant area. However, a tooth fell out. So it's like all on three with one less tooth. Now, this is the absurd going in the other direction. Is this case a titanium deficiency or college tuition? Now, Pecos, you got 2 dental schools to worry about, so we could change that to dental school tuition. There are more implants here than there are natural teeth. Besides Isaac, who would do this treatment plan. Now, here are some of my thoughts on Malo protocol, who created the concept of all on four. The first one was a myth, that there were poorly placed implants, and then they just created a whole school of movement around the implants being tilted in the wrong direction. Turned out not necessarily be true. There was folklore that it was developed on a napkin. That actually turned out to be true. Bo Rangert is a biomedical engineer working with the Nobel Group, and he and his colleagues modified and improved the so-called multi-unit abutment. Biomechanics confirmed. John Brunsky, if any of you know him, he's world famous biomedical engineer in the United States. But there were clinical issues, bone quality. So imagine if you had a bone quality issue and you have something like osseodensification to improve your outcomes, you're really in good shape. Patient finances. I showed you that the cases are a little bit less. Am I already done, Bernie? I have 5 minutes to go? Oh my God, I gotta go forward. The dentist skills for augmentation. How many of you can do the type of augmentation that you've seen at this meeting? Hopefully all, but it's gonna take some time. How many teeth are needed? Do we know that answer? 10 or 12, 9, 7? How far back do you go? It turned out that the big smiles, the first molar, you don't need to go past that for aesthetics. Yo, Mo, love you, man. I'm gonna give you a Cam Newton. Okay. The dab, we're gonna dab a little bit, yeah. Functional needs, too many implants. Sometimes too many implants compete for the vascularity of the bone. It's not a good idea. But the star of the concept was something called the multi-unit abutment. Apollo, I took some training with him. Oh, who showed lovely children? It was Isaac, all the guys with young children showed happy young children. I had the like low 20s, upper teens. I take them on an expensive trip, and I take pictures of triangles wherever I am. And they're sitting there all burned out, another triangle. Anyway, places around the world. Now, 2 of these people are patients in the practice. I have no idea who she is. Anyway, you can look at their smiles. We all know that smiles vary, but none of them go back past the first molar. Gans, I have to give him credit because he talked about the triangle of bone, which is important when we do our planning to know, are we going to use angled abutments, custom abutments, stock abutments, is there available bone, type of augmentation that's necessary. I love this article by Joseph Kahn. He looked at cases that were already done at their dental school, Loma Linda, and broke it up into classifications based on the bone anatomy. So we're lucky that God and Mother Nature together gave us 81% of the population with this kind of bone. However, if we went down the socket, which osseodensification doesn't necessarily suggest, we'd be doing air integration cases. We want to go up in this direction, which we know that we can do. For the left-handed people, we're that way. All right, 12, 3, and 3. This is the worst case. There's no bone. However, Ziv sees this case and says, I'm working on this patient 20 minutes and I'm going to build up the ridge. We all can do that now based on what we learned at this conference. The gap. How many of you know who the famous Hamletian periodontist Dennis Tarnow is? We all know Dennis. I've talked with Dennis before, and I said, Dennis, what do you think? To graft or not to graft? That is the question. Come on, gut, you thought that was funny? There. Okay, so Tarnow and his group did report a case report. Why am I showing this? Because I use this concept almost every day. They took a case, they took out a tooth, they didn't put any grafting material in it, it was protected by a provisional, they got histology afterwards and found that there was only about 1 millimeter of buccal to palatal bone loss. Here's the article right here, International Journal of Perio and Restorative Dentistry. There's the histology in a socket, no graft, pretty big gap. You know, people used to say, oh, 1 millimeter gap, nothing needed. 2 millimeter gap, maybe. Grind up teeth. Maybe that's good. Maybe it's needed. Maybe it's not needed. Anyway, this is what they did, and that's what they got in histology. It's a case report of 1. That's enough for me to deal with. Now, Big Jack Hahn, you may know him from your education as well. He had a concept called playing the bone. What did that mean? He would drill up and down, slow and fast. He would do all the osseodensification concepts, not even really knowing it was osseodensification. He would put the implant in a little bit, rotate it out, put it in. He would massage it into place. And it was a great concept, and I love him as well. In 2011, we did this book, Babish, Hahn, myself, and Rosenlicht. Notice, we had all-on 4 type cases in a book that was published in 2011. To do a book, who did a book in here? It's like 3 years to get a book out. So, you know, it's like an older thing before it even comes out. So, in my practice, there are 3 typical maxillary case types. A patient that's edentulous at presentation, a terminal dentition, and a failed or failing implant case with or without the existing implants. Think about it and you would say, yeah, I kind of agree with that. So Professor Bronnemark, his big goal in life was to treat edentulous patients. No patient should go to sleep with their teeth in a jar. Right, Sam? Okay. Terminal dentition. Who knows who that is? Close. Right country, wrong sex. No, it's Queen Nefertiti. Who knows who this guy is? $100 if you even know the state where he lives. Ooh, San Francisco, we got to win that. But where exactly does he live? Which, come on, a little bit more, you're getting there. I got the 100 for you. Anyway, he lives outside the Marriott Hotel at the San Francisco, near the convention centers, and I've seen him at 2 different perio meetings. And perio meetings in San Francisco are like 6 years apart. So I would say, hey, how you doing? He goes, ah. And I said, what's up? He goes, I want money. And I said, if you smile, I'll give you 5. No, I said, I'll give you $1. He goes, no, I want 5. And I said, give me a big smile. But it's sad to make fun of this guy, but he's a terminal dentition. Here's Father Leonardo. Do we love him? Who showed Leonardo pictures at this meeting? The other 2 Italian guys and me. I love Leonardo. Oh, by the way, did you notice that? Look at what he was talking about, proportions. He wasn't even a doctor. Very wonderful man, Michelangelo and Leonardo. Terminal dentition, look at that. So, look at this guy. A retired dentist from New York. All of his friends were teachers at NYU. That's funny. Anyway, look at his case. Look at his case. I did that on purpose. Look at his case. Look at his case. Towel, look at his case. Then on top of it, I'm a retired dentist and I don't have any money. How many in this room don't have any money? Raise your hand. Okay, so there's a couple people there. So you report down here. Okay, what's his chief complaint? Number 7. Look, Jack, may I call you Jack? Sure. My number 7 keeps on falling out. What do you want? I think it's broken. I go, it is broken. What do you want? I want an implant. And I go, Who can't do an implant there? Everybody can do an implant there. But is that what we want to do? How much is an all-on 4 case? Like $25,000, let's say. How much is an all-on 4 lower? Let's say $25,000. Let's say you're doing them both together. So 25 plus 25. Since we're doing them together, Picos, what do you got? 70. 70,000 for both arches. So I said, I could send you over to Tampa area, coastal jaw surgery. Picos will do it for 70. We'll do it for 66.5. I'm a retired dentist. I have no money. I never treated the guy. But I want you to look at this. Can you do anything on this patient without like working on his occlusion, the lost, forgotten art? So in the all-on-4 concept, we have tilted and straight or axial implants. The tiltings on a cross-arch relationship make a series of triangles. And when you start looking at mechanical things, when you go to the airport in Orlando, you'll see struts that are triangle. When you go over a bridge, you'll see triangular struts. It's a very important engineering concept. Then on top of it are the multi-unit abutments. So the concept benefits are immediate function, shorter healing time, favorable bone, tilting implants. The literature is robust in the area. The mandible, it's over 10 years. Maxilla, it's over 5 or 6 years now. It's a biomechanically sound because it improves the anterior-posterior spread. Earlier at this meeting, I saw my dear old friend Doug Klepper, if you're still here. I took one of my very first training courses with Doug and Charlie English. And they were my teachers, and I'm grateful that they're here, or that Doug is here. Graftless solution. What does that mean? Without doing grafting. Now that could be a good thing. Keeps the fees down, your skills are not in challenge, and it's been shown that on 4 implants it works. Maybe this is true, that you get some practice growth. Lee Hauer, do you get any practice growth from your all-on-4 cases? Yes, good. Okay, so here's an example. Here's a typical panoramic. We're going to do implants. We want to get back to the first molar. If I did a first molar without a graft or without osseodensification, I would have a 6.5 implant. But if I put a tilted implant anterior to the sinus, I get a 21mm implant. That's 3 times longer bone implant contact, and we had brilliant presenters the other day showing us what happens at the bone implant interface. Same thing on the other side. So by doing 4 implants, you get as much bone implant contact in this triangular biomechanical concept. From looking at it from the side, that's the ideal placement on the medial wall of the sinus. And we have done osseodensification at the medial wall, and we've pushed the medial wall in. Think about that. It's like a very cool thought. So my children are still being dragged around doing all-on-4 stuff. My daughter lives in Charleston. That's the Ravenel Bridge. Have any of you seen that bridge? Is it a nice bridge? Beautiful bridge. So we walked over to the top. I started taking pictures. I did the all-on-4 salute. And there's triangles all over the place. I love triangles. Ah, who knows what this is? Huh? Nobody knows what it is? Second to the Last Supper. Now, let's look at this for a second. We have 3 colleagues here. We have 3 colleagues here. The Holy Father here. 3 colleagues here and 3 colleagues there. So you may look at it and say, ah, Leonardo, it's amazing. I look at it and go, tilted here, here, and here. We're looking good. But there's even a triangle around Jesus here. So it's a beautiful thing, and I love Leonardo. Multi-unit abutment. They've been created a long time, so they're actually out there and proven. This part here, the connection, varies implant system to implant system. Most of the companies now, the cone is being standardized, so it's conforming more to the original one from the Nobel Biocare group. So this is an anatomy lesson. There's a cuff, a connection, a cone, and an abutment screw. The 0 degree has no abutment screw per se because it's a one-piece concept. Now, there are closed trays and open trays that fit on top of the cone. There are people that swear by the open tray concept, and there are people that prefer the closed tray. They both exist. The abutment screw goes in, locks it in, and this connection point varies per implant system. Brunsky has proven, based on lab studies as well as in vivo models, that it works. The prosthesis can be gorgeous. Let me ask you a question. Will you have a Chewbacca experience with these kind of prostheses? No, because you're not going to get recession here. You might get recession of the tissue in the bone, but you're not going to get a Chewbacca thing. So That's what we decided to do. In the lower, I did some post-op cone beams that it shows that we could actually place the implants on an angle and get them favorably positioned in the bone. This passed the GANS test of acceptable placement, good anterior posterior support, the guy's happy. Okay, true computer-guided surgery is not what I'm doing. True computer-guided surgery is a template is created based on the fabrication of the data, and you can see the multi-unit abutment here. Now, guided surgery, it's actually simple, right? You first have to match a person with clinical experience to know where the implant should go, to treatment plan them where they should go, and then number two, they should have good computer skills. What I've found is that the younger colleagues, they could just look at the software and they could put the implants all over the place. The older guys like Picos, it takes them maybe a year and a half to figure out how to work the software. Michael, is that true? You even hired that guy to do your lecture, 2 guys to do your lectures. So that's what I'm saying. So it is not simple. It is not simple, but we can learn it. It's a wonderful thing. I get blown away when I see guys like Isaac. All of a sudden, they're like C guys and things coming from here and STL files. Does everybody even know what an STL file is? Huh? Triangles. I like this guy. He's a funny guy. You were the guy with the good aesthetics, beautiful aesthetics, right? Yeah, you're good stuff. All right, Gans. He writes this book. Now, this book saved my life because in this book, there was a chapter called the classification. You could have diagnostic freehand, meaning you look at the cone beam, you get information, and then you just go freehand and place the implants. Then there's template assisted, meaning you use a template that's been created for that patient. There's 100 different varieties. And then there's the true, fully guided template. I've been using the template assisted now, and I'm going to show you in my next group of time. So here's a failed lowercase, terminal dentition. You can see that easily. We move right along. We take the teeth out. We smooth the bone. This is a template, and the template has a trough. As you see here, the trough fits perfectly, the whole template fits perfectly in the mouth because it's going to be a replica of the final prosthesis, and then it's made clear for me to fiddle around with. It's not as sophisticated to some other guides, but the purpose is to allow me to place the implants pretty much in a freehand way, but I verify the positioning with the trough. Then I'm able to verify the position of the multi-unit abutments because you could reorient them as the case goes. Case comes back from the lab one day. Some people can do it the same day. And the case gets put in the mouth. Look at this. Cast to the mouth, to the mirror in 4 minutes. Now, I'm not saying that every case will go like that, but it is very predictable if you have the implants in good positions. You put the multi-unit abutments in good positions and orientation. The case should just slide into position. Here's the installation the next day. Patient comes in. I always use absorbable suture materials to allow for no suture removal appointment. They just melt away. So here's a very skinny arch. Plenty of bone, no problem here. This upper case was done many years ago. A little sedation. Same thing, same kind of template. What are we going to do here? So I do a block section of these teeth. That's a lot of fun if you're a periodontist. You like almost think you're like a Picosian oral surgeon. Now, speaking of Picosians, is Lindsay Pico still here? Where? Oh, there you are. Do you have any idea what I'm doing over here? Yes, she said something about the nerve. Exactly. Michael, it's been worth every dollar. You must palpate the nerve. How easy is it to find the nerve, the mental foramen? You find the mental foramen, you know where you are. You can mark it on the ridge, and therefore you're not going to get into like some legal challenge. Implants go in. Some people put them in deep. I don't like it putting in deep because I'm going to put in this abutment that has a bulbous base to it, the cuff, and we want to make sure that they can seat all the way. If you get it right at the crest, there's a bone profiler with most of the systems. Well, again, we use the trough. Good anterior posterior spread. I like the screws coming on the occlusal or more to the lingual aspect. Flat or convex intaglio surface is critical because how do you think the patient can clean if it's a concave? They can't. They just develop all sorts of, like it's a McDonald's growing underneath. Happy patient, okay. Tilted straight. Now, we start thinking about bone density as it applies to the upper jaw. High stability, we talked about at this conference, and we know that it's a prerequisite for successful immediate load. It's been written about as far back as the 7 and 8 Esposito articles. Insertion torque. We had the guy that developed the first papers, Treasy. He was here yesterday with us. His 2013 paper, Schnittman and others have studied that. Bone density, soft bone, what do we do? How many times did you hear about under-preparing? So these things are in the literature. Agliardi, I showed his case earlier, Charles Babbage. If under-prepping is not sufficient, you make it longer, maybe a little wider. Ole Jensen, who is one of the key surgeons of the Clear Choice group. Treasy, he showed this to us actually yesterday. Micromotion may be related to force and torque and density. Now, my thinking is densification will improve bone density, and improved bone density will lead to greater implant stability, which should lead to improved and more predictable outcomes. Does anybody not agree with that? If you don't agree, you could get a refund on the tuition. Maxillary case, thin bone, 9 millimeters. Trough, here are my ISQ readings, but this allows me to place the abutments into position. Here's a 63, a 71, and so on. This is the only patient that I'm going to share with you where I lost an implant at about 3-year point. Her case was installed, and I'll show you which one I actually lost. This one. Now, I don't know whether it's prosthetics, if it's soft bone, if it's me, if it's the team. It was a series of things. Just last week, I got a note from my colleague that the prosthetic fractured, and when he was putting it back together, that implant was loose. So we're going to fix it. Here's another case of terminal dentition, broken down prosthetics. We need to have at least 15 millimeters of bone from the incisal edge, not bone, restorative space, from the incisal edge to the crest of the bone to handle the abutment and all the restorative materials that are going to be stacked on top and to be strong. So we sometimes have to make a little cut. So everything that we saw at this conference, we're like preserving bone. Here's a time when you might need to take it off. I use the ISQs a little bit above the bone crest. You see how the abutments are fitting within the trough. And the insertion appointment the next day, absorbable materials, and she has this case in position. So 4 months, everything is pretty much healing up in a reasonable way. And down the road, it's looking good. Happy smile, nice lip support. So about a year later, everything is looking good. I was giving this lecture in San Francisco, so I knew I needed to give it a little colorization. Now, who knows what this is right here? Huh? Huh? Okay. Oh, it's not politically correct? What, San Francisco? Let's call it Colorado. Terminal dentition. I sometimes draw on x-rays to show the patients what's going on. Very nice guy, Richard. Broken down. Look, this guy was not shy of going to the dental office. He just kept on having things break. Nice looking ridge, plump. We could do a lot of things. I start taking the case apart, and you'll see some things that are under the definition of a terminal dentition. Even crown lengthening done by Mark Gutt would not work there. Put in the implant, 76. All right, it's good for Isaac. Now look at this. I put the implants into extraction sockets. All the time that I do these cases, sometimes they're in sockets, sometimes they're in the edentulous area, and I'm not doing grafting. Is it wrong? Maybe. If you want to do grafting, it's okay with me. But Tarnow showed us the case in point, the proof of principle, that's not necessary. 71, the tissue is the issue, the bone sets the tone, and the buccal plate sets your fate. Now, I wasn't sure I was going to show that because I figured 30 other people would have shown it, but the buccal plate setting your fate is the new twist. Tilted implant with a 75. Now, look at this. I bet you all my other colleagues, speakers, would have probably split it, did something with it, but it's not necessary. You got good bone here, good bone here, good bone here. That said, I'm not saying this is the only way to treat this particular patient or case type. Implants are in. I think he had 5. And the case is there. Again, flat is a requirement. Anterior, posterior spread is ideal. He was on a blood thinner, so you would expect a little oozing and bleeding and discoloration, but he healed up okay a couple days later. This is him about a week later, maybe a week after that. Stitches are going to melt away, and he's doing fine and dandy. A couple of years later, he comes in. How's your golf game? How many of you shoot 84? The guy's like 84. Terminal dentition case. Now, this was the case that I showed Salah. If I might have like a moment of digression, probably, if you don't give it to me, I'm going to take it anyway. A few years ago, it was 2 AID meetings ago, you were on a display, and I read about it in the handout. And I said, this is an interesting thing. I like to think about density. So I walked over to their booth, and Fred was there, and Salah was there, and they were like transacting some business. So I got Salah, and I said, I want the 4mm drill. So he said, well, no, you need to get the kit. And I said, no, I just want the 4. And he goes, well, you don't understand the concept. No, I just want the 4. Then a real customer came over, and then he sold the kit. Then I went back, and we went back and forth, and they got a bunch of customers, and I didn't come back for the next year. So it took me like a whole year of wasted density. I promise I'll be done in 14 minutes. So this case was one that I showed Salah, and he liked what I was doing with the densifying the cases. A little soft tissue manipulation. Here I'm marking my guide. Trough densification. So we're putting them in. Look at this. The high initial torque insertion that everybody was talking about goes hand in hand. This is at the Nobel 75. Nobel active. You could do replace rapid. I think that's what it actually was. Replace rapid. 77. I'm getting there, Isaac. I'm coming along. So implants are in. Not all the way down. Did I graft it? No. What will form in there? According to Tarnow, maybe bone. But it's stable. It's at 77. I'm okay with that. We did a occlusal adjustment with like a little, what do you call it, reduction template. Take down all the high spots, put the case into place. Patient comes in the next day. We're ready to put the prosthesis in. Occlusal adjustment. Everything is looking good. His case working out okay. My last case. This guy comes in about 2 or 3 weeks ago. I need my teeth by Christmas. My cone beam was down because I'm in exchange of getting a new Carestream cone beam, and it was down. We had a panoramic, which is this. These implants were failing. He wanted an upper and a lower immediate load case. He had money. It was coming to the end of the year. I had Christmas payments and things. I figured we could do it. Talked to my teammate, and we said we're going to do it. So I engaged a cone beam company to take the cone beam. Now, let's look at the maxilla first. Here's an area that Ziv can build a whole case. Nothing here at all. A little bit of bone in this, like premaxilla. Nothing here. Pretty interesting something going on here. What's his history? I'm the 3rd maxillary implant case for this guy. He had a conventional case, failed. He had sinus grafts, failed. He had a lower implant case, failed. Our blood clearance said he had nothing like was unusual, like failing bone factor. He just had problems. So we said, all right, let's see what we can do, and can we get it done like really fast? This is his cone beam. It's like not a lot of bone. The lower was not a big problem. He had tons of bone there. So I could do bone blocks, maybe, or send it to Picos, maybe. I mean, there's a lot of things we could do. But he wanted it done before Christmas. So I'm carefully looking at it. Then I make a plan. And I said, you know what? I'm going to put a longer one here. I'm going to do one here. Maybe I could tilt it this way, put it up here, tilt it this way. Look at this. If I get one right in that one zone and do an osseodensification, it would be like a very cool thing for this guy. And I said, do I want to do osseodensification under and in the nose? And I said, I don't know, Ziv would do it, so I'm going to do it too. So I know I'm putting him up in the nose here. So that's like an interesting thought. So he comes in, we take him down, the lower, is that the lower, I don't remember, the lower. Now, I took an intrasurgical x-ray because of two things. I wanted to see where I was with this bone here. I wanted to see if I was here, but I wasn't. And I wanted to be here. The lower, we were good. So then I moved myself back, and then I got right where I wanted to be. So I was able to be where I wanted to be. 65, 66, nice readings, my drilling protocol, my trough, 5 implants went in. My colleague did some measurements and impressions. Everything is like coming along okay. Case is done before Christmas, wasn't Christmas like Saturday or Sunday? Sunday. I think it was put in either Friday or Saturday, so we came right in the wire. But let's take a look. This is what my plan was, but in the discussion, I decided to tilt it that way and that way. And these are, this one and this one are in the nose. This one is a pretty good spot with our osseodensification sinus. Everybody would be happy to do that now that we're at this conference. So let me take a closer look at this. So after all this guy has been through, is this really the best we can do for this patient after he was pushing us and we worked hard to get him done before Christmas? I don't even think that's attached or fits. I'm sad. I'm not even sure that one fits. So I told my teammate, I said, all right, the Christmas holidays are done. You got to do this next week. So I think they're going to do it next week. Anyway, if plan A doesn't work, there are 25 more letters, so be cool. I like art. I found this in some museum. Actually, I think it was in Israel with dentition. I like trolleys for some reason. So I go around the world and I'm looking at trolley cars. There's old trolleys and newer models. So summary and conclusion, osseodensification is compelling. With the all-on-4 concept, bone density and the understanding of the components is critical, but osseodensification does appear to improve the initial stability. So again, with trolleys, you could stay on the track that you're on, this one here, or you could take an adventure going in this path here. Now, who knows what this means? What that means is if you don't know, go that way. So I told you I was David. So thank you for your attention. I hope you enjoyed the symposium, and happy to be with you.